and we will answer everything, or I will. Oh my God, Katie, that's my goddaughter right there. Well, one of them.
Oh, with one of them.
I'm glad, so glad you here. Oh, that's for you, Carissa.
Um,
So I did want to talk about a little bit of how does a patient like Carissa get offered research? Because I think a really big mental block that individuals have is that if I'm being offered research, I'm going to be a guinea pig. And that
mhm.
is a huge stereotype that we try to combat. Chemo is the killer, not cancer. I have mixed emotions with that sentiment, Queen Bee. Yeah, because, and Katie, I'm sure, has strong
Yes.
opinions here too, because our work, and I'm saying our, Katie and I, is to find alternatives that are not necessarily chemo, but rather immunomodulators or immunotherapy, which is us developing medications that retrain your body to combat the cancer for you. When you are young, you have cells in your body called NK, or natural killer cells. They're a type of leukocyte, or a type of white blood cell, and its job is to destroy cancer. That's what it does. And if you think about, for those of you that are older on the call, the 90s craze that you needed a healthy tan. There's no such thing. But you're cooking in these tanning beds, and then suddenly you get a mole that wasn't a mole, it was a melanoma. And so, from that approach, you have this mentality of like, okay, oh, wait, do you think there will be something besides? Oh, yes, let's talk about that.
Oh,
So
yes.
that's exactly what we're doing, right? Because chemo, yeah, chemo does a great job at, yeah, go for it, please. Yes. I will say with these NK cells, the reason why at 16 you don't have a bunch of 16-year-olds with these horrible cancers and melanomas is because our skin cancers are controlled, and any other cancers, by these NK natural killer cells. The problem is they're very expensive to make. If you think about like the way your body allocates resources. So there comes a point, and it's about when you're in your late 30s, I'm getting close, where your body stops making them. It kind of like your brain has to make a decision, and it's going to choose to take care of other stuff that's going on with your body than making more of these. And so their population in your blood decreases over time. And then when you're about in your early 60s, you don't have any left. And so you no longer have these scouts that are looking for cancer that it needs to eat and destroy. And this is how you ultimately, around the ages 60, I think, Katie, correct me if I'm wrong, the average age for cancer diagnosis is still in the mid 60s, right?
I believe it still is.
Yeah.
That said, I have noticed certain trends. Yeah.
Yeah, it's also, we have, I was going to say, like colorectal cancers, Katie can
Hmm.
vouch, has had a huge spike in a much younger population. So, but I will say that is the bulk of Katie and I's work, has been how do we develop things that are not chemotherapy? Chemotherapy is great. It's really good at its job. It's just also really good at kicking your ass. And it's like,
Yeah.
I only wanted to kick cancer's ass. But
And it's not always the most appropriate route to go, depending
exactly,
on what you're being presented with.
precisely. I will see in the general sense where chemotherapy is really good at just kind of locking down and being like, okay, you're not going to grow anymore, regardless of the cost to your body. That cancer is not going to grow anymore. Immunotherapies, the approach is, can I retrain the white cells that you still have in your body to do the job of those natural killer cells so that now you're doing it from an internal perspective. And what we're looking for is how do we control any side effects that it might cause. In case I'm going to backtrack now because the immunotherapies that I've worked with kidney are very different from the ones you work with, except for maybe Pembro.
Oh yeah, definitely fun,
So take the oh, hello from Trinidad. Nice to put oh, hi, Empress.
bro.
Hi. Yeah, it's going to be real international up in here. So, Katie, could we talk about what immunotherapies you're working with right now?
Oh, yes. So, of course, we have our, as mentioned, the Pembro. That's been one of my biggest ones lately. Um, Sorry, I'm referring right now to my list of my active studies.
You're good. I will say, we're gonna talk about medications with very short
Hmm.
names like Pembro. But for those of you on the live, all of these medications will end with the suffix of lizumab. So pembrolizumab or nivolumab, anything like that. So if you hear that MAB at the end of the name of a medication, it means it's a monoclonal antibody, MAB. And so these are immunotherapy type drugs, and these are the ones that we're mainly focusing on for cancer research because their kind of list of side effects that patients go through are, number one, more mild, and number two, I think we can even say less frequent. So that when we say Pembro, we're talking about brand name is Keytruda. So you've probably seen commercials about Keytruda. Go for it, Katie.
Yes.
Yes.
Yep, makes sense. So we also are doing toripalimab.
Tor.
That's a bit of a newer one I've been working with lately. And of course, nivolumab, as you mentioned. And I have and forgive me for the pronunciation on this one, petosemtamab. That's another newer one that we're working with lately. But we have our classics that we always go back to. And yeah, those are probably like my biggest ones right now. Oh, and durvalumab, zanidatamab.
And Katie, why the preference for the immunotherapy? What side effects are you not seeing with immunotherapy as opposed to chemo with our gastric patients?
Okay, specifically with gastro patients.
Mm. Yeah, I think we could talk gastro and then colorectal. I think those are going to be, and
Okay.
pancreatic, I think, are our big three.
So it just overall seems to have
Mm.
lower toxicities. It seems to be easier for a lot of people to handle, while also still attacking aggressively enough cancer. Just overall, that's the big scope of it. It's less toxic, but effective. And it's often paired with other things to make the most of it. Mhm.
Absolutely.
Yes.
Um, when we talk about immunotherapy, that component in the front, immuno, has to do with immunomodulation. So that's literally us manipulating your immune system to kind of hijack it, but for our own good. So yes, cancer cells are able to do a lot of what I call deregulation. So things that your body normally has a really nice kind of structure, it's able to hijack that for its own advantage. And I did want to address Empress's comment here. My father-in-law is currently doing chemo, and while we have great and free oncology centers here, some of the prescriptions are hard to get and very expensive. That's
Mm,
actually why I left, which I still hurt, Katie. I miss working with you so much.
good.
We used to work like around the corner from each other, y'all. Um, but that was why I wanted to make more of a patient impact, but not at the bedside, the way that Katie still works, but rather facilitating the expense that comes with research and with cancer treatment in general. These medications are horrendously expensive. And it has to do with the work that Katie and I do. It takes so many, you know how this it takes a country to bring aboard a medication. And I hope your father-in-law is doing well, Empress. But it takes anywhere, I was going to say, it takes anywhere from 7 to some medications that we work with have taken over 15 years to come to market. And that has to do with all of the safety parameters that we have in line. And if the data that we're collecting, can I join? Sure, you can join. Drop whatever questions you'd like to talk about. But when it comes to making sure that the medications are safe, at the first thing that kind of leads us in this is we must do no harm in our pursuit of good. And that was really the first thought of why we should start moving away a little bit from chemo. Is that, if I give you a medication that's what we call a general approach. So like Carissa was mentioning, getting chemo, I'm attacking everything because the target or the searching mechanism of this medication is, oh, I'm going to look for anything that is rapidly dividing or growing really, really fast, because tumors, we know, grow really, really fast. And so it does a really good job of that. The problem is, especially with our GI cancers, is that our our lining from our mouth all the way to our anus is also rapidly dividing, because every time you eat, those cells have to replenish themselves. So unfortunately, chemo thinks that they are also the bad guy. And so you get those stereotypical nausea. Well, I always say it's the Pepto-Bismol commercial. Nausea, heartburn, indigestion, upset stomach, diarrhea. That is what you see. Yeah, and his last CT indicated that the cancer spread to his bones, so we're just hoping for the best. I really hope they're controlling his pain. I am so sorry he's metastasized. I'm so sorry.
Yes,
I'm sorry. And
that's
Empress, if you need
extremely.
anything, you know that you can always message us. Um, mm, that's fine. That's no worry. I'm pretty sure the Tiki-Talkie gods deactivated the cross-sharing thing because they don't want people on other platforms. So that's fine with me. Is that okay with you, Katie?
That's totally fine.
Thank you. Is it too late to introduce immunotherapy? Katie, what do you think? If he's on chemo now he's metastasized.
So it really depends on what his cancer is and anything else, like with the if he has any mutations going on, whatever else.
Hmm.
Yeah.
Yeah, Empress, I may have blocked you. Did you mention what his diagnosis specifically was? And if you did, I'm sorry if I missed it.
Yeah.
Yeah, I will say, in the context of, for example, I'm going to shift gears just a little bit, but in the context of, for example, kidney cancer, it's never too late. It's never too late to introduce immunotherapy, because at the very least, we can do it what we call palliatively. So with the understanding that I'm not going to cure you, I'm not even going to really be able to stop the process of what's happening, but I will be able to mitigate additional issues that you're going to encounter. For example, kidney cancer also likes moving to the bones. And so if I can give an immunotherapy after a patient has metastasized, or now they're getting growths in other places other than what we call the mother tumor, the originating tumor. If I can do that, then I can delay pain. I can delay in the bones if they start getting extra holes from these cancers, because they kind of munch at the bones. If I can delay that growth, that's less pain, but that's also less likely that the patient's going to break that bone, right? Because now, if you think about your arm, if you have a hole here and a hole here and a hole here, and then you go and you pick up maybe a heavy bag of groceries, you might break your arm. But if I give the immunotherapy, I might be able to lessen how quickly that process happens. And there's also additional medications we can even give. Um, there's one called that comes to mind, Exgiva, which is kind of like it's like a sugary kind of medicine. We inject it into you. It's given via an injection, and it coats the bones. It actually protects your bones so that the cancer munches on the medicine instead of munching on your actual bone. So sometimes what we give is not necessarily immunotherapy to treat, but we give all kinds of other things to like distract the cancer and just give you as good a quality of life as possible. Mm. Mhm. Oh,
Yes,
yes.
thank you.
I was going to say, Katie, do you want to go into that? Because Katie's very passionate about this distinction.
Yes. Yeah. Like Ursula was saying, they are hospice is not at all the same as palliative. We say palliative for stage 4 cancers, which is just we can't cure it, we can treat it, and we'll see where that takes us. Mhm. Yeah,
Mhm.
exactly.
Thank you,
Yeah.
Empress. Yes, and also, I also want to add just an extra little caveat that even if we're not talking about hospice, palliative care has this mentality of it's the end and there's nothing to be done. And hospice is already, I always say, hospice is still an active verb. We're still doing things. We don't just abandon a patient. But palliative actually holds hand with actual treatment because what happens is, and we're trying to kind of emphasize this more, when you are getting treatment for something that is painful, cancer hurts a lot. And depending on the type, it might hurt more or less, but it hurts. And so the way I think of it is if something's broken in my car, I'm not going to take it to Burger King. I'm going to take it to a mechanic. So if I have cancer, I'm going to go to an oncologist. Now, that might be a surgical oncologist, a radiation oncologist, a medical oncologist, but I'm going to an oncologist. I don't want the oncologist handling my pain. I want them treating the cancer. Palliative medicine is to treat the pain. Their job is to calibrate. You're going to get a little bit of this and a little bit of this and a little bit of that. And we're going to do this every other day to make sure that you have a very tailored approach to your pain while we are treating your cancer.
Mhm.
Mm-hmm. Yes.
Yes. Perfect.
Ooh. So, Katie, this is for you from TK.
Hmm.
So, her grandfather has pancreatic,
Okay.
and it is stage 3 right now.
Okay.
So, will there ever be a cure?
I honestly think that we get closer and closer every day. I have seen stage 4 pancreatic cancer completely respond to treatment, and I have seen that same patient. I'm specifically thinking of one person who she uh, is in remission. There are so many things now that can be done and acted on that we are seeing either outright quote unquote cures or life that is extended beyond what we ever thought before for a lot of these GI cancers specifically. But yeah, I do think we are trending more and more. Pancreatic is a tough one. I will say, jumping off of the GI cancers for a second, I will say that in our lifetimes, every single person on this call, I believe that we'll have a cure for hormone receptor positive breast cancer, all of it. Like we will absolutely, we are just about there. So we're getting there with everything.
Yeah.
Yes. Hmm. Yes. Right. Yes.
So I wanted to just jump back to Empress, who's come back in, and it's prostate cancer, which is my forte. I worked a lot with prostate cancer.
I was about to
Um,
say,
I was called the
our,
kidney queen for a while, and then I got thrown on a bunch of research for prostate cancer. So, interestingly enough, prostate cancer does not respond very well. to immunotherapy. And the reason for that is you keep hearing Katie and I talk about targets. We're targeting things. That means that if you think about a bullseye with your darts, right? You need that big red dot in the middle to know where to throw your dart. If I don't have those, that's where the medications that we're using, like chemo, which are more general and don't necessarily need a target, become more useful. So it's very common for prostate cancer to metastasize, and specifically to the bones. And that has to do with, I did send that by accident, Queen Bee. I'm sorry. I meant to tap on Empress. I said it. But the reason that this happens is that many cancers eat what you eat, right? It's a part of you. But prostate cancer is, for the most part, what we call hormone sensitive. It's a hormone muncher. So for a man, their main hormone is testosterone, and so their cancers just munch on all their testosterone. So the first course of action we do, and you might recognize some of these words, Empress, we give something called Lupron or Leuprolide. And so that's a medication that actually stops the man's ability to make testosterone. And so we essentially starve the cancer. Like, it's, if I take the plate of food away, it's going to die. The problem is it then mutates, and those mutations are what become actionable, what we can attack. And so far, the research that's there, we have not found something actionable that immunotherapy can do. But we do have several that chemotherapy can do, and we do have some in prostate cancer. I'm thinking about one in particular is very aggressive, which is docetaxel. Anytime you hear the word taxol in a medication's name, that means it's taxane. These are very aggressive. These are very general medications. So the determining factor, Katie had touched on this, that it depends on the patient themselves. We will look at a human and they have the exact same presentation, but because one of them is younger, I'm going to treat them differently than I'll treat the older patient. And so that is really the determining factor here. My husband's dad has prostate, but with medication surgery, it's no longer an issue. Exactly. Prostate cancer, like Katie mentioned with breast, I think we're like right there in either finding an actual cure or making it so that it's a cancer that you just hold hands with your whole life. So the way that you think about, hey, do you have any medical history? And people are just like, oh yeah, I have high blood pressure. We are that close with prostate to just be like, oh yeah, I have prostate cancer, but I mean, it doesn't do anything. And that for me is a huge success, right? That you can just hold hands with your cancer and go through life and it doesn't dictate anything. Unfortunately, I think we're a little far. You think we're far with pancreatic, Katie?
Unfortunately, yeah, just because of the nature of it. Chris explained it very well, how unfortunately, how much it hijacks. And again, it, like many other GI cancers, you don't get a diagnosis until typically you're already at stage 4. So a
And
lot of the times.
can you remind, because I remember when the week that I was working on one of your trials, I'm pretty sure it was a pancreatic. Can you talk about the symptoms that we look for when we're dealing with a gastric patient? I know you always talk about yeah, we can talk about all of those, but with gastric, I remember you always said that when a patient says, I feel full after a couple of bites of food, it's the immediate red flag.
Oh, that's the pancreatic is definitely early satiety. Absolutely, yeah. And so I've even made myself worried a few times. I've gotten full quickly and then was worried I might have something. But another thing also that pancreatic cancer can do is because it's affecting the pancreas, patients can also end up developing diabetes,
Mm-hmm.
which is now a whole new thing we're dealing with. Mhm. Yeah, yeah.
Let me take a look. Talking to the doctor seems like two different languages. We hear that a lot, Empress. We hear that a
Hmm.
lot. And this is why when Carissa approached me about this, I was like, I have to get Katie on the phone. Like, Katie has such a control of what she knows that she can make everything just easy. to understand, and not scary, which I think is so huge with this. My issue was I ate and it just sat in my stomach and I would get bloated with lots of pain. Yes. Gastroparesis is definitely,
Oh yeah,
yeah.
yeah.
Katie, can you talk about gastroparesis and how it may or may not increase your risk for a gastric cancer down the line?
Oh man. So I'm not unfortunately as well versed in gastroparesis, but in its direct link with um, GI cancers. But there's definitely something there. Like if you think about the what's happening with the nerves, blood flow, everything else that's whatever's causing that gastroparesis, if it's not, idiopathic or anything, if something is causing it, there's probably a few other things happening behind the scenes. And then all of that backing up, it starts to be a domino effect also. Then, the rest of your gut's not moving correctly and other things are building up in there or sort of um, the, I guess, sort of die. Yeah, yeah. Ah, oh,
Yeah.
yeah. Mhm.
I was
Yeah,
going to
that
say
makes
it's definitely getting center stage because it is one of the more severe side effects of these GLP-1 medications as well, which
yes.
with all of their fantastic benefits, if it does trigger gastroparesis, this is an immediate no-go and you will not receive that medication again.
Right. And so I was also thinking about with the gastroparesis, with things like not literally a delayed emptying of stomach. So eventually the sphincter between your stomach and your esophagus, it won't be able to always close, quite literally if it's too full. If you've ever really gorged yourself on a meal, there's this sort of weird nausea you'll feel, and almost like an acid reflux. So that's part of there's things like that that'll start out. It's because the sphincter can't close. That's if you've ever, again, maybe like me, gorged yourself on a meal and you feel that. So but thinking about that long term, so we have definitely certain indicators for, say, esophageal cancer. If you have Barrett's esophagus, which comes after a long term of GERD, gastric reflux, all that, eventually it can lead to Barrett's, which can then lead to esophageal cancer. Um,
Oh, good.
yes.
We're getting a lot of love from Mike. Hi, Mike.
Thanks, Mike.
I did want to scroll back a little bit. We had a couple of bubbles pop up. Okay, so how do you get diabetes too? Oh, let's talk about this one. So I'm going to talk about it from the endocrine side of it, and Katie, if you wouldn't mind,
Yes.
then taking the treatment side of it.
Yes.
So the pancreas has very important cells on top of her, and most importantly are your beta islet cells. And I'm not going to try to spell that, but beta islet cells, their main job is to create and secrete insulin and glucagon. These are two hormones. Insulin, I'm sure everyone knows about. Glucagon, not so much. I'll talk about insulin first. So insulin is the one whose job it is to get released by the pancreas when you've eaten, for example, and go through your blood and grab onto those sugar molecules from the food that you ate and it has now been broken down. And that insulin is what brings them into a cell so that you can eat, right? Because your stomach eating is just the first step. It has to get absorbed now, of course, Queen Bee. So once it gets absorbed, that's where you're feeding every individual cell in your body is getting some of that food that you ate.
Mhm.
The other side of that is, well, what if you're like starving? Like you left home, you left your bagel in the toaster oven, you don't have time to stop for coffee, you didn't replace your snacks at work, and you know that you have a meeting at 12 o'clock, so you're not getting a lunch break today. What do? Well, you're not going to pass away, right? Like your body does something to compensate for the fact that you're not eating anytime soon. And that is the release of glucagon. So this one is kind of like your sugar reserves, where it's like, y'all, we're hungry. And it'll secrete these bonus extra kind of packages of sugar that you have so that your brain can keep working. Unfortunately, because of the way that these treatments work, those islet cells can start to deactivate or downregulate. So when that happens, suddenly you're eating and you're not secreting the insulin that you need, or you haven't eaten and your pancreas is not able to receive the signals of we're hungry, and so it never secretes. And so both of these, there's different types of diabetes: type 1, type 1.5, and type 2. I'm going to give the floor now to Katie on how that happens treatment wise with these cancers.
So one of the complicated things is a lot of patients that are coming in with pancreatic cancer, a lot of them are already coming in, a lot of times with already having a diagnosis for type 2 diabetes. So there is some question of which comes first, but also because one of the other things is with insulin, um, hold on, insulin promotes cell growth, which sort of ends up creating this negative feedback loop that fuels the growth of cancer cells. So you end up with that also. That's why it just kind of ends up being this mess in there. So much is compromised. Um, and then I'm just thinking also about, just real quick, like thinking about when we have patients on treatment for cancer, we also give them steroids a lot to help with the first like 3 days, like after they get infused with a drug or something, we'll give them a short run of steroids. But the problem is steroids can also increase your blood glucose, which is also not what you want. I'm sorry, my cat's yelling in the background.
She's
Oh,
cheering you on. You're doing so good, Katie.
oh, thank you. So um, it's one of these things where there's some amount of affect of the of sugar overall. I don't want to then make everyone scared and try to run away from sugar, because while it can feed the cancer to some degree, not entirely, and we give plenty of, we've even used metformin itself as part of a treatment for directly attacking the cancer. So it can be done. All of it can be done.
Yeah, it's a valid question, TK.
Hmm. 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 Hmm.
Yes, and just to go back into the chat, Queen Bee, metformin is amazing and helps my husband. It's a fantastic tool for sure.
It
And
does so much.
yeah, and TK, just to reiterate that a little bit, when we say sugar, I also want to say this: every single thing you eat, your body will convert to sugar at some point. So even for, I've had patients that say, I'm going to go completely keto. I'm never eating sugar again. I'm only eating meat. You will still produce, or rather break down your food
Hmm.
to a sugar molecule. It is the easiest way that our body could interpret it when it comes to eating. So it still comes into your body. You still need it. When you think about the way that, for example, chemotherapy affects your body, where your hair might fall out, your skin might turn gray, and things like that, depriving yourself of a macronutrient like that will also cause those same things. So, what Katie was talking about, like, we don't want you to be afraid of sugar. I always say, when it comes to cancer, I don't care what you put in your mouth. I need you fed.
Yes.
And when I say fed, remember that, and this is going to be a little personal for those of you on the call, but TK, remember that plate that we did for your science class where it was like, this much has to be vegetables and this much has to be fruit? Remember that? That's what I'm talking about. When I say I need you fed, when I put that plate in front of you, if all you were able to eat was the chocolate chip cookie in the corner, I'm thrilled, because I need you strong to fight this cancer with me.
Yes.
And that's the biggest thing. I hope that makes sense.
Hmm.
Absolutely.
Absolutely. Hmm.
Mhm. Oh, we've got some moving and
Yeah.
grooving here. Let's go.
I
Let's see. My
so
nana had. I'm sorry.
yeah.
Go ahead, Katie. I'm sorry.
I was gonna say I noticed some of the how do you know when to stop fighting as well as the that someone's nana fought for years.
Yes. Mm-hmm.
So
Those
I'm
are.
not I of course am not ever saying that you shouldn't, respect what, the struggles that they have gone through, that any cancer patient is going through. There's sometimes I want to lean away from saying they're battling cancer and then because the end result a lot of times of they lost their battle with cancer. It's it can be sort of it's a difficult language to ascribe to it.
Because it's almost like if
Yeah,
you lost your battle, makes it sound like you didn't try hard enough,
right.
right? Like, 'cause you think about it, like, oh, you failed the test, you should have studied harder. And
Mm,
I'm very much of the same school of thought as Katie, where, and I'll bring my own father. My father's battle was with his lung cancer, and I had to rationalize this with my mom. My mom was like, he needs to fight, like and I was like, you're not asking him to drink a glass of water. You're asking him to let a doctor give him essentially poison as medicine. And that's very hard. And when someone chooses to stop, they are not quitting, they are choosing to rest. And it's important. And one of my doctors that I worked with before, Dr. Carthon, love you, man.
mm,
He said it best all the time, where he always said, it's never been a battle, it's always been a journey. And I will hold your hand on this journey for as long as you can. But I need you to also realize that when I let go of your hand, it's time for you to let go too. We don't make it out of here alive. None of us, so that's the thing, is that the ultimate, right? Like, none of us, unfortunately, we will not make it to live to be 600 years old. None of us can. So, age, family, children, grandchildren, all of these are contributing factors of how much someone may want to push themselves. But TK, to just specifically address how do you know when to stop fighting, only the patient knows that. Because even the physician, Katie, and myself as researchers, will sit down and be like, hey, your scans don't look great. This is not what we wanted. We can keep pushing. We have a laundry list of other clinical trials. This new drug was just approved. I had a patient that had a lot of, he flew to the
mm.
UK for a treatment that they had
Yeah.
there for his prostate cancer. But we will tell you, I don't recommend pursuing this, because when we start this cancer journey, one of the things, at least what a good physician will do, is say, what do you want to get out of this journey? Oh, I want to make it to my daughter's wedding. That's in September of next year. Okay, then that's our target. My job is to get you to September of next year. Maybe your target is, I want to see my children graduate high school, and your children are 4 years old. And this is where we need to have a really realistic conversation about what your cancer journey will look like, because we know for the most part how these diseases react.
Mhm.
Non-Hodgkin's, and I did want to talk about that. Your Nana was a beast, Queen Bee.
Mhm.
Oh, yes. Yes. And I'm
Yes,
trying to
I
also
did
like
notice
not
that.
scroll away. But yes, so I'm worried about the possibility of GI cancer as a patient with ulcerative colitis. Katie, that is all you meant.
Yeah, so I was going to say, so while it can increase your risk, it doesn't necessarily mean that you'll definitely develop, or even there's some amount of risk there, but depending on the type of ulcerative colitis you have, and of course, if you are following with a GI doctor right now, um, you have eyes on you to be checking on things, keeping up with things, and to hopefully, be able to mitigate any issues that may arise, anything that starts looking to be precancerous. My cat is, I'm sorry, around my ankles yelling at
No,
me.
she's your
She
biggest
wants
cheerleader.
food. Yeah, but definitely wanna encourage you that it's just keep up with your regular physician. It's there's a risk that you should be aware of and think about and consider, but by no means should you live in any kind of fear and an absolution or anything of thinking that it will come.
And Taylor has responded. She's on. I'm just going through the motions. They have me on Entyvio and Bution. Okay, those are. I'm out of my depth when it comes to the medications of ulcerative colitis. However, if you're under, like Katie was just saying, if you're already being watched, that you're already doing the right thing.
Yes.
That's our struggle with a lot of our patients. I can't tell you how many patients will say, "Oh yeah, again, I'm going to talk about kidney cancer," but I'll have male patients be like, "Oh yeah, I've been urinating with. There's been blood in there, and it's been like that for like 6 or 7 months."
Hmm. Men, I was gonna say.
I will say, not just men. The number of women that I yell at because we are the first ones to put everyone else in front of us, where we will ignore our symptoms because, oh my God, but the kids have to go to school tomorrow. And then Jenny has band camp and I have to get Chris to his baseball practice. And suddenly you've been dealing with a lump somewhere for
Hmm.
years. And, so I will say it goes both ways. I will say the scarier ones tend to be my male patients. Yes,
Right.
for men it is fear, and sometimes it's justified. My father's fear was that his first daughter, Annie, she was, believe it or not, doing. She. My dad called me her second coming because she was the most giving, sweetest creature to walk this planet, and it was donating blood. They screen, of course, your blood, make sure you don't have any kind of, you don't have, HIV, of course, but also if you don't have any kind of viral infection, bacterial infection, because they don't want to give it to whoever gets the blood. And they gave her a call and they were like, "Hi, we can't use your blood. Get to a doctor right now." And they were the ones that found her leukemia.
Yeah.
And my father, unfortunately, my father walked into her bedroom one day and she was actively passing away. The way that leukemia ultimately takes your life is that you develop something called thrombocytopenia, which is a big fancy word for you have no platelets. And you need the platelets to clot your blood. And so, unfortunately, my father held her in her last moments. And so, when he knew that he had a tumor in his lung, he's like, "No, I don't. No, I don't. We're not talking about this. No, I don't." And that was the conversation I had to have with my mom. If I don't force my patients to do treatment, I'm not forcing my own father. And ultimately, he did choose to do treatment. Hmm. That's a really, really. No, 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 you're fine. You're fine. Hey, Jay. TTP is a scary disorder. Which is TTP? Hmm.
Right.
Yeah, absolutely.
As a quick note, the leukemia, I don't know if perhaps the audience may be on the younger side, but my first introduction to anything about cancer really was through these books that I would get at the school library by Lurleen McDaniel. She had specifically a series called 6 Months to Live. And it
Mm.
was about a young girl at about 12 years old being diagnosed with leukemia and then her journey with that. So my initial introduction to the world of oncology and actual treatments for it was this. dramatic sort of book series written by this woman who writes that she would write about all sorts of kids with chronic and or fatal illnesses. It was very interesting. I do recommend them. They're fantastic for that age bracket. But I I used to think that all treatment was an inpatient sort of deal. You had to be admitted to the hospital. You would automatically lose your hair, all of this. And then while there are definitely, especially leukemia and a lot of other blood cancers, you're probably going to have to go be admitted for a few days initially for the first few doses of whatever treatment. You're not living there for 4 months like I used to think that you would. I have plenty of patients who go to work, live their lives, do all sorts of stuff. Yep. Right.
Uh-huh.
Mm-hmm. Yeah,
Yes.
absolutely. Yeah.
I did want to address, we got three questions at least rapid fire. So
Yeah.
TK, yours is going to be more involved, so I'm going to skip down really quick. Cancer alone is scary, but it's getting checked to catch it and guide their journey with them. Absolutely, Queen B. But you are doing, that's the hard part, right? Facing your fear and coming to see us before there's something there. You're, I know it's scary, but you are doing exactly what you should be doing. And
Absolutely.
Michelle, to talk about this. Is it possible to shrink tumors without chemo? Absolutely. The majority of Katie and I's work is in immunotherapies or immunomodulators. And so chemo is actually, it can. I'm not going to say it doesn't, because cancer will die in response to being exposed to chemotherapy, which will, of course, shrink the tumor, but it won't make them disappear entirely. Chemo very rarely is able to do that.
Right.
But what immunotherapy can do is, because we're re-engineering your existing white cells, your existing immune system. Um, Carissa mentioned this before. Cancer is able to do this, and your white cells are like, "Where's the cancer? I don't see anything," but it's there. But what it's
Hmm.
doing is it's releasing all kinds of kind of counterintuitive signals that are confusing the rest of your body, so that I can't see them. Immunomodulators, and suddenly it's like, "Oh, that's a tumor. Hold on, I'm going to munch on that real quick." And so that's our job that we have done. And I mean, we could sit here with a long list: dopatatamab, pembrolizumab, nivolumab,
But
ipilimumab.
your
So many.
PDL1s, your PDL1
Dose.
inhibitors, all your stuff, your
Yes, all of
things
these
for
modular,
that.
even conjugate drugs.
Yeah.
Conjugate drugs have been, they're part chemo, part
Hmm.
immunomodulator. One of them is called enfortumab vedotin. We use it in bladder cancer. Also gives you the benefits of the immunotherapy, the benefits of the chemo, and we're kind of in the middle when it comes to side effects, which is great because then we have the control that chemo gives us, the shrinking that immunotherapy gives us. But with those patients, we don't see nausea, we don't see vomiting. And then patients like Carissa who are like, listen, I have to work. You can't give me a medication that's going to land me in an ICU.
Hmm.
These don't. There's other stuff we're watching. I don't want the picture to be like, oh, they're perfect and nothing happens. That's not it. They do have their own side effects, but it's not. Thank you, Mike. It is not. Oh my god, my pumpkin. But it is definitely not that stereotypical. Oh my goodness, Katie, could you take TK's question? Does the cancer in your intestines give signs too?
So it does. So I wish Carissa could have seen me earlier when she was discussing her journey to diagnosis. I was just nodding along very hard, but it's very similar to a lot of patients go on that same journey of, well, I'm having some indigestion, I'm having some bouts of diarrhea, I'm having some bouts of constipation. Those are going to be your first signs, and then it's going to be you're going to know at some point. One of the best things you can do is be in tune with yourself and recognize when, okay, I know that I didn't always eat the wrong thing. I didn't eat something that upset my stomach this many times to be giving me these symptoms every single day now. or far more frequently than I'm used to or would assume. So that's always a good thing. One of the other things is I know they are starting to trend towards doing colonoscopies younger, not enough. But again, as we've seen with, like in this earlier this year, we had James Vanderbeek get diagnosed with colon cancer, and um, things like that. Like, yeah. Sorry, no, I didn't hear all of what you said. Yes. Oh, yes.
Yep.
Hmm.
Mm-hmm.
Uh,
Mm-hmm.
uh,
Mm-hmm.
mhm. Yeah,
And the
yeah.
only little thing that I'm going to add to this, my mom is a chronic sufferer of gastritis. So she's been on medications called PPIs or proton pump inhibitors.
Yes.
Um, she's been on them, oh dear God, I think she was diagnosed in her 20s and she's now in her mid 60s. So math, right?
Hmm.
And so this is goes back to the comments that have been made about it's so scary to be constantly in that journey of going to the doctor and checking and then thinking it's today the day. The earlier the detection, the better. My mom tells me all the time. She just had an endoscopy and colonoscopy done. She was having a lot of what we call gastric flares, right? Like, despite taking your medicine the way that you should, you still have this heartburn. You're still super uncomfortable. It still hurts and stomach cramps and all these things. I promise you, it is so much better if we find anything and I put you in Katie's hands. Katie has a toolbox with 15 things she can do,
At a minimum.
versus exactly versus you ignored it, you ignored it, you ignored it. And now
Hmm.
Katie's like, okay, I've got three options and you're not gonna like any of them, but we can try.
Yeah.
Well, we rationalize.
Hmm. Right. We love it. Mhm.
And
Yeah.
Katie, I want to drag you into Michelle's question. Hi, Michelle.
Yeah.
Is colon cancer genetic?
Oh my goodness. It absolutely can be. So that's also, I was about to say that. That's another thing. Arm yourself with information about your family background. Additionally, even to other cancers, it's going to help inform a lot. So we want to know about everyone in your family that has had cancer that you're aware of. We want to know as much as you know because it's going to help inform us about certain things for you and possible links. And then also encourage you, especially for people who have kids of their own, to go and get genetic testing done, not only to see what we can work with genetically in terms of treatment for you, but also so that we're prepared to help your children in the future and even your children's children. Absolutely. Yeah.
I was going to say,
Hmm. Yes. Yes. So that's actually interesting. Yeah, we have a lot of our treatments actually for breast and GI use the same drugs. And
mhm.
we also even have, you'll hear HER2 a lot for breast cancer. We also absolutely, HER2 is something we always look for and have plenty of actionable drugs for GI,
And I
for
want to throw
everything
in
angio.
from my side and from my neck of the woods, prostate as well has HER2 we've recently discovered. So across
Wow.
the board, we have three disciplines here of medicine in the kind of medical oncology sphere. I actually have a really funny story, but it's getting late, so I'm not going to bore you guys. But um, the residents sometimes are like, "What do you mean I'm treating a prostate cancer patient, so a man, someone who was born a man, with this medication that when I was doing rotations in breast, I was treating women with? What are you talking about?"
Hmm.
And it's our attendings that are like, "Yeah, because it's the same. Remember what we talked about before? It's the same target. We've got that HER2, that HER1, that oh my god, what's the other one? The RAS. It's
Yes,
that same marker. Yep. And so
absolutely.
yeah, and it's fantastic. This is why I mean I'm sure Katie can echo this. This is why I love science, because they'll be like, wait a
Hmm.
minute, my stuff works for you. Here's 20, take them. So
Yes,
of course,
yes.
I haven't seen any movement in the live in the comment area. If we don't have, what just happened? Oh, okay. All right. So it is a school night. So if there's no more questions, oh, there's my mom, guys. Say hi, mom.
Hey.
We were just talking about the gastritis. So thank you all so much for being here. Katie, I love it. I miss you so much. And I still have your birthday present. I
Aw.
need to see you. I need to see you.
Yes, thank you. Yes, thank
Of
you.
course. No, thank you for the idea, because I always wait for someone to say, like, let's do a talk about blah blah blah. And I'm like, sure. So Katie,
Yes,
thank you for answering when I
of course.
answering my call. I sent out a bat signal and she was like, yes. No worries. And to answer Tele, yes, I can. You tell me when it works. I will gladly talk about bladder cancer as my boyfriend.
Woo.
Yeah, sure. Absolutely. Of course. And Queen Bee's sending thanks as well for the information. My father in law getting his cystectomy. You did tell me about that. You have to tell me how it goes. You have to tell me
Nice.
how it goes. And GK says thank you as well. Oh, someone says hi, mom. Tele says hi.